But the bad news is MDG 5, which is reducing maternal deaths, has not been achieved. Another good news, 64% decline in underprime mortality, and the decline has been very good. But the MDG target, and many countries of our region have achieved MDG 4, many countries haven't achieved MDG 5, but as a region, because other countries could not achieve, MDG 4 also has not been achieved. So what is the challenge in front of us? The 11 countries of Southeast Asia region contribute to 26% of world's population and 36% of global births, which is more than around 37 million. 61,000 maternal deaths, 1.5 million under 5 deaths, about 1 million newborn deaths, and similar number of stillbirths. These are tragedies that are preventable and can be prevented. On the coverage and quality, so where are we with it? Why it is happening? We know, I'll just give you two examples. For example, deliveries assisted by stillbirth attending, we see a very variable coverage. Some countries have got to 100%, 70%, 90%, but other countries are still at 30-40%. So the women are not getting safe attendance at birth. Breastfeeding initiative can within 1 hour such a simple intervention, and we know it can really impact the survival, is also very variable. So there is an uneven coverage across countries. These are missed opportunities. How come a baby is brought to the facility for immunization, but when the child suffers from pneumonia, he doesn't get to the same facility with the same health worker and for antibiotic. Immunization coverage is 90%, but when we get to diarrhea treatment, pneumonia treatment, it's very low. So there's uneven coverage and there are missed opportunities into the system. And we know if a woman comes, 80% of women come for first antenatal checkup, and when we get to fourth antenatal checkup, it drops down to 55%. So these are missed opportunities where our system is not able to really get them into facilities where they need it the most. It is very interesting. A baby or a mother who lives in a poor family in a rural remote area is not educated, has a much higher chance of dying than somebody who's a rich person living in an urban area and is educated. So what are we talking about? Equity differentials. So across, even for different coverages which I mentioned, I'm sure these slides will be given below. We find that against the red quintile, but we have data now on literacy and also rural urban literacy. Where are deaths happening? Deaths are happening in the rural areas, amongst the poor communities, amongst the illiterate or non-literate mothers. So equity is very, very important. We are not reaching everybody. We know what can save the mothers and the babies. RMC interventions are very known, but coverage remains low. I am getting distracted by the sounds and the talking. Could you please observe silence for some time? So interventions we know how can we save these mothers and the babies, but coverage is low. Against the whole continuum of care at different levels of facility, evidence-based interventions have been identified. WHO and other partners have identified interventions which can save these deaths. There are evidence-based guidelines also, which have been adapted by most of the countries of our region. And these guidelines have been adapted, training packages have been developed, people have been trained. So these are at different levels. So we are talking about two continuums. One continuum is home, care or community level interventions, first level facility interventions and the hospital. So the continuum of the health system. The other continuum is across the life course, starting practically young, when they are adolescents, with preconception care going to pregnancy, birth, postnatal care for the mother and the baby, maternal health, infancy and childhood intervention. So these two continuum, we have enough evidence, we have enough evidence-based interventions. But we need to move from guidelines to changes in the practice. So these guidelines are there, training packages are there, but has it really led to practices? No. We know that immediate crying and delayed cord cupping helps the baby, but still, immediate cord clamp, delayed drying and suction should be practiced in the hospitals where women are delivered. We know that skin-to-skin contact is good, but still the babies are separated from the mother in the hospital. So these are just two examples I have given. We know what works, but we are not practicing that. Now with the Lancet series coming on, triple return on investment, reducing maternal newborn deaths and stillbirths. So what is the critical time? Which is the most important time during the life of a mother and a baby, that if they get that particular care, they can be safe. It is the pregnancy care, which is linked to small dividends, care around childbirth for women and newborns, and care for the small and sick newborn babies can give you triple returns. It can prevent newborn deaths, maternal deaths, and stillbirths. So the focus has come that this is the critical period in which we need to provide good quality care. We know the effective intervention. These documents are there on the WHO website. We know what works, at what stage, how much deaths can be reduced by each intervention. We know that 70% of the newborn deaths can be prevented by high quality coverage, which is 90% with available intervention. And when I showed you the first few slides, in some countries coverages are very low with the effective interventions. And we can also say 80% deaths related to preterm and low-birth weight, and half of neonatal survival depends on better maternal care. Are we investing? Are we short of resources? And I think if we look at our total health expenditure, we know that very few countries are really investing well in the area of health. And you can see it ranges from about 1.4% to 11.4%. So there is a lot of out-of-pocket expenditure. People are going to private sector and spending money to get good quality care. In other words, the poor is becoming poorer because they have to go to the private sector, or even in some countries within the public health sector they have to spend resources. It doesn't come free in many countries. There's a human resource gap. Density, recommended density of health worker per 10,000 population is 23. But then look at the resource gap, except Maldives, rest of the countries are just touching it. The shortage of doctors, shortage of nurses. Again, a reminder for the silence, please. My humble request. Thank you. So there is a shortage of human resources. As I said, we are spending less on health as percentage of GDP. We are also short of human resources. The poor quality of hospital care. Now we know that a lot of people are, the demand for care is increasing. Many people, because of our community-based health workers, community-based volunteers, many people are referred to hospital for care, but the quality of care invariably remains poor. Priority is not done, standard clinical guidelines are not practiced, inadequate skills in emergency care. And there are few examples from Bangladesh, India, Indonesia, Nepal, and now India also, where we have supported quality assessment, and it clearly indicates there are a lot of gaps and challenges. So in other words, we are shifting the place of debt. We are shifting the place of debt from home to hospital if we don't provide good quality care. The health system information system, information system is weak. Many countries don't even know how many births and how many deaths are there. We don't have a good data on central registration of vital events. So what are the challenges to progress in Southeast Asia region? Coverage and equity gap. We are not reaching everybody with good intervention, life-saving intervention. Quality gap, even when they come to the facility, they are not given quality care, and accountability gap in terms of what is happening there we don't know because of the weak health information system, incomplete birth and death registration, and inadequate review of maternal perinatal deaths and response. What are the digital initiatives? Our new regional director who joined 2 years back, the moment she joined, she decided to have several flagship areas, and one of the flagship was unfinished agenda, ending preventable maternal newborn childhood deaths with focus on neonatal deaths. Southeast Asia Regional Technical Advisory Group has been constituted. These are some of the members from within our region, and the global experts are the member of the Technical Advisory Group in Southeast Asia. A joint statement by 6 UN agencies, regional directors, UNICEF, UNFPA, UNH, World Bank, UN, WHO, our regional director led a joint statement, signing of joint statement and release of this joint statement so that the UN agencies can work together in supporting the ministries of health in ending preventable maternal, newborn and child deaths. So there are a lot of work. We have supported countries in developing regional national strategies, fostering these strategies. Capacity building exercises have been done, and there are a lot of resources on newborn, sick newborn care, essential newborn care which are available. We have a neonatal perinatal database as a part of the network which we are talking about, and which will framework and tools for improving quality of care. INCI is scaling up well in the countries, and this is the situation. There are 5 countries where it is getting to about 100% scale up of integrated management of child diseases to save children from dying from pneumonia, diarrhea, undernutrition, and some newborn deaths. Quality of care, as I said, we have guidelines, we have tools which have been used in Bangladesh, Nepal, Indonesia, and now India. They are practiced there. So assessment is very important before you can take action. So many countries are adapting these tools to improve quality of care. Similarly, maternal and pregnancy death surveillance and response, we just finished the meeting last week in Maldives, regional meeting. There are modules on cervical cancer which have been finalized, and there are family planning practice to share us where we are and where we want to be. So MDGS, which is maternal death surveillance and response, is moving ahead, and newborn has still got audit and response has been added. Now beyond survival, we are adding life to the years. Early childhood development we know, and we have a regional strategy on early childhood development for first 3 years, and we know that investing in early childhood development is a powerful equalizer for addressing equity issues. And this is for children below 3 years. Multiple entry points can be used, which have been restricted. I am going to read these slides for you to read so that you have a reference to what we can do in early childhood development. It's very interesting. It's very interesting that as the newborn mortality and the underlying mortality comes down in countries like you can see Thailand, Sri Lanka, and Maldives, the causes of death then become preterm, birth asphyxia, and birth defects. 35 to 55% of deaths are happening because of prematurity, asphyxia, or sepsis, and birth defects. So birth defects are becoming very important because of this virus outbreak now, because of the microcephaly. We have not established a causal relationship, but then this is something which the surveillance is important. There is a strategy, regional strategy on birth defect prevention. There are 9 countries, including Myanmar, which have a national birth defect plan on surveillance and prevention. We know surveillance is the key to prevention. And there is a web-based network app that's been launched recently called Newborn Birth Defect Surveillance. It's a web-based as well as mobile-based. We can use this to report on birth defects, to report on sick newborn, to report on dead births as well. And we have about 150 hospitals across countries which are reporting on data. And it has been very helpful for us to establish a baseline for Zika, for safety microcephaly because of the Zika outbreak. What is the global agenda? My request again for your attention, please. This is very interesting. So now I told you what has been done in 15 years, and now we are moving into a new era. And we should not wake up in 2025 as we did earlier. There is a global strategy which has been launched, which is for women's, children, and adolescent health. This is a UN Secretary General Strategy 2. The first one was only on women's and children's health. And they said we cannot ignore young people, we cannot ignore adolescents. So now the strategy also has adolescents. It has 3 main objectives: survive, which is to prevent deaths; thrive, to ensure health and well-being, so it's not only to save them if they are not going to be productive population; and transform, expand enabling environment related to food security, water, sanitation, hygiene, all those things are included. So what is new? And I said, whatever was the challenges in the past during the MDGS phase now has been addressed as part of the global strategy. Focus on equity, universality, focus on adolescence, because somebody who is 10 now will be 24. So there will always be they will be mothers by the time we reach the end of SDGs in 2030. Right course approach and multi-sector approach. So these are the targets for survive, thrive, and transform. I will not go into details, but you can consult these slides because of the shortage of time. And it's very interesting. There are high returns on investments in women and children and adolescents health. Tenfold return on investments from social and economic benefits, and $100 billion demographic dividend, $100 billion demographic dividend from early child development and adolescence. Huge dividend which we are getting. And most of the countries of our region have a demographic change and demographic dividend which is coming from the young populations of our countries. So moving from MDGs to SDGs, as Madam Chair said, SDG 3 is health and well-being out of the 17 SDGs. So what is going to happen new? Please pay attention. Look at the targets now. We have reducing child mortality by 2/3, MDG 5 years maternal mortality by 3/4. Look at the targets now. By 2030, reduce the global maternal mortality ratio to less than 70 per 100,000 births. A tough target for many countries to reach, where the maternal mortality is still 200, 300. And 2030 end preventable deaths of newborn and children under 5 years of age in all countries to reduce neonatal mortality as low as 12 per thousand. And you will see that in our countries with 30, 40 neonatal mortality, getting to 10 is 12 is tough, and under 5 mortality by 25. So these are the new SDG targets for survival. So the unfinished agenda of MDG 4 and 5 has been already taken into SDGs, where the reduction in mortality remains important. SDGs are affordable because the price tag of full implementation of the agenda it is estimated from 3.3 to 4.5 trillion per year. But there is a progressive realization. Countries will, of course, proceed with their own pace, having their own national target setting. I know somebody was telling me, now it is about 200 plus targets of SDG, but then the countries have to choose these targets to monitor. Estimated cost is imprecise right now, and so there has to be investment cases which need to be built to really get to increase the domestic funds investment as well as donor funding. SDG will be largely financed from domestic resources and market-related borrowing, not from governmental assistance so much. So I think countries are leading this whole process. So who's going to fund? Like you have Gavi, you have GFAPM. So there is a global financing facility, the GFF Trust Fund, which has been created, and it's very important for you to understand the what's and the how of GFF and who is the part of the GFF. There are partners which are listed here. There are different approaches which have been identified, and there are different goals. So that means the countries have to work on investment cases. Complementary financing is possible through the system. Technical assistance will be coordinated, and coordination of monitoring and evaluation. First wave were these 4 countries, and the second wave, Bangladesh, India has been included. But then now we are in discussions with Myanmar to see from the GFF, Global Financing Facility, some funds can be leveraged to support implementation of RNSA work in Myanmar as well. So moving forward, I think accelerating mortality reduction is the main issue of the countries, and WHO and other UN partners are on board to support it. We have to get to the targets of SDG. We missed as a region, we missed this time, MDG 4 and 5, and the countries who achieved it are feeling very sad about it that we as a region we could not achieve. Improving implementation across continuum of care, strengthening the system, strengthen program building, planning and management capacities, reaching the unreached, improving quality of care, addressing social determinants, because that's something which is very importantly addressed. Because SDGs in health, you have to work across sectors. Only then you can have gains. And improve coordination among programs and partners and beyond survival, maximizing development and quality of life. So everyone has a plan till they get punched in the mouth. Nepal earthquake is a one, there are countries are planning, they are moving on track, but some natural disasters happen and some outbreaks happen, and Nepal earthquake is one example and followed by some border disputes where a lot of houses were destroyed, health centers were destroyed, hospitals were destroyed. In that kind of situation, your maternal deaths, newborn deaths, child deaths are likely to go up. Your adolescent issues are going to be more related to mental health and post-disaster trauma, which is happening now in Nepal. Then Ebola strikes, a lot of resources get diverted to Ebola from global level. The pot remains the same. So from the same pot, the money is coming to the countries and to the donors. But then when these kind of exigencies happen, the funds are affected. And now with Zika virus, I think we are again, it's an opportunity as well for countries where Zika has not come in. birth defects. Every baby is born. If you can better connect circle friends, look at for other birth defects. Upload onto the web-based system. I think you can track your surge of the cases and any outbreaks which can be related to it. Friends, I end here. Thank you very much for your patience. And the question is not if we can afford to do it. The question is, can we afford not to do it? Because 2030, the new targets is a question of a challenge for all of us. But along with this challenge, there are a lot of opportunities at the global agricultural level which we are coming up with, where the countries can really make sure that no mother, no newborn, no child dies, and they remain happily and they eat the way you had your food today. Thank you so much.
Thank you very much, Dr. Nina Reiner, for your very complete and informative presentation on global and regional overview. May I invite the second speaker, Dr. Chitram Marie Silva. She is a specialist in public health and immediate past president of College of Community Physicians in Sri Lanka. And her main area of work is in field of reproductive health, and she is Deputy Director, Maternal and Child Health in Ministry of Health. She was also past President of Perinatal Society in 2011 and an Honorary Fellow College of Community Physicians in 2014. She has numerous scientific papers and operational manuals and annual reports to her credits. And shall we listen to the success story of Sri Lanka to be given by Dr. Sidramali Silva. Thank you.
First of all, I would like to thank WHO for inviting me to do this symposium to do the presentation of success story of achieving MDG 4.5 with Sri Lankan experience. So Sri Lanka has a very historic development of healthcare system. We have a pluralistic healthcare delivery system, which was indigenous medicine was started 2,500 years ago, and we have many evidences in our religious background to show that what has happened. And also the Ayurveda and indigenous medicine has a long history, and the allopathic medicine started somewhere 1505 with the colonial era. The rules and regulations on public health, especially on controlling communicable diseases, sanitation and environment was in place. This is how the care for the mother and the child has been evolved over the last few decades. So you can see the prenatal, the first initiative is the development of the establishment of the maternity hospital. That is one of the first maternity hospital in the whole of South Asia. Started in Sri Lanka as the results of maternity home in 1879. Then we had the development of public health field-based primary healthcare system, which was started in 1926. And then we had the national level coordination by the Ministry of Health, by the establishment of Family Health Bureau Villa Alber in 1968. Then the national policies and the national program was implemented throughout the country after that. In 1978, we elected the Almata, after the Almata conference, the primary healthcare concept and the health for all by the year 2000. Safe Motherhood Initiative was implemented from 1987 onwards. Then we committed for the Millennium Development Goals in 2000, and now in the process of committing for the Sustainable Development Goals. So this is a picture of the first territory that was established in 1926, and our public health midwives were working at the grassroots level, very high at that time. So the national policy and strategic direction, we had policies and strategies which focus on uniformity in health system in the decentralized or devoluted health system in Sri Lanka, national policy on maternal child health, national strategic plan on maternal newborn health, and the adolescent health. These are some of the documents available at the national level. I think as Dr. I mentioned, we always emphasize on the continuum of care across the health system, home community, first level facility, and also the hospital base. Equity, quality, and also facility of interventions for all the life cycle approach, full life cycle approach. So where you can see how the organized continued MCH care is delivered through our primary healthcare system, where the public health midwife is a grassroots health worker who is working at the grassroots level. Her care starts with the registration as an eligible family, where there is a woman between 50 to 49 years of age, and then she is provided with pregnancy care before she becomes pregnant. Then the antenatal care provides as answers and years. Intranatal or the delivery care, we have 99% of our deliveries happening in institutions, and also 94% of the deliveries happening in comprehensive emergency hospital care institutions. Then the postnatal care is delivered either at the institutional level at the beginning and then followed by the domiciliary care. Infant and child care again to the public health midwife and the community staff and into the institutional system. Care for school child, the adolescent and the group. Recently we initiated the adolescent and infant program at the Ministry of Health, and we are linking with many other stakeholders to strengthen services for adolescent and the group. Family planning services is integrated into the maternal and child health services, and it is provided by the public health midwife, the public health system, and also the critical institutions through the delivery of MCH care package. So as I said before, the care commences before pregnancy. So the care for newly married couples through the eligible family care is a new concept that we have adapted. So both the husband and the wife are requested to come for pregnancy care. So they are provided with screening and the services at the public health system. Antenatal care, all evidence-based, internationally agreed upon interventions are packaged and provided with clinic-based care in specialists and non-specialists by the specialists and non-specialist medical officers, and also the domestic care which is provided by the public health midwife. Recently we revised our maternal care package, and now we are implementing the revised field maternal care package. At the postnatal period, again, continuum of care happens. So the midwife is supposed to visit the woman at least 5 visits or 4 visits during postpartum period, and she has to look after the mother and the newborn, ensure that the breastfeeding is established and attend to breastfeeding problems, and also all the newborn care problems have to be attended, and then she refer for necessary care. And also the family planning services. Throughout pregnancy, the couple is counseled on family planning and ensures that the couple or the woman uses a method of family planning at the end of the period. So you can see 350,000 arrivals are happening annually, and 94% of these deliveries are happening in teaching hospitals. Those are where the comprehensive emergency hospital facilities are available, and only 5% of the deliveries are happening in the private sector. You can see we have a strong system where for the maternal death, the postmortem is mandatory. Every maternal death, the postmortem has to be done at the institutional level, and the comprehensive emergency services are linked with the laboratory services and also the blood transfusion services. So we have nearly achieved 100% coverage of antenatal care from in-source. about 98% from the government source. Syphilis screening among the pregnant mothers is 98%. Toxoid protection identity is 99%. Average genital home disease biomedical school. And also the early initiation of breastfeeding and obviously post-natal care is 78%. We had to do a lot from that. So Sri Lanka has committed to international declarations that were the for all 2000 LCPD program of action, that is the National Policy on Population and Reproductive Health, was passed by the Cabinet in 1998. MDGS and also the SDGs. So we set our targets on MDG 4. MDG 1 was reducing the prevalence of underweight among 25 years. So we had a target to achieve. Then reducing child mortality. We set our targets based on the internationally agreed indicator, and for us to reduce our under 5 mortality rate to 8 and infant mortality rate to 6 per thousand live births by the year 2015. And also the immunization against measles to be 100%. You can see what our achievements are. We could not achieve the really set targets because our interventions to some extent we were not spending much for strengthening the advanced newborn care. So that may be one reason. And also we started at a lower rate. So therefore, further reduction of total reduction is not very easy when you started at a lower rate. And also you can see out of the infant deaths, 75% of the infant deaths are happening at the newborn period. So you need to strengthen advanced newborn care for further reduction of our infant mortality and also the other mortality. So if you look at the causes of infant deaths, IUGR, prematurity, low birth weight, birth asphyxia are some common causes, and also the congenital malformations and the birth defects have been accounted for nearly 20% of our infant deaths based on the hospital statistics. Again, child mortality, you can see the same causes are the major killers of children under 5 years. So to meet the challenge, we have to strengthen our quality of newborn health services, regionalizing newborn care services to improve provision of advanced newborn care, establishing neonatal transport services with the ICU system. So that we have already started initiating the work, and also strengthening neonatal surveillance system, which is mainly through the hospital-based HMIS. Then the human resource development, we have to think of task shifting of our human resource categories to introduce new services. We are now preparing our 8 newborn action plan, which is in progress, and we have already completed bottleneck analysis on newborn care. And also the birth defect surveillance system we have initiated, and it is being now pilot tested in 2 districts. And also the fetal-infant market surveillance system has been already started, and we are collecting data on that and conducting review meetings as well. When you look at MDG 5, improving maternal health, MMR, we have reduced to 32 per 100,000 lives in 2015, but we could not achieve our target of 23. And also the contraceptive prevalence rate, our target was to have 72%. We achieved 68% of coverage in 2006 DHS. We are now waiting to get the DHS survey data during this year to confirm. Adolescent birth rate, our target is to achieve 24% and 28% about the last DHS, which was conducted in 2006. Antenatal care coverage, 1 visit is 100% and 4 visits, it was close to 90% based on the routine HMIS which was conducted last year. Unmet need for family planning, our target is to reduce it to 7%, and the last week is recorded a rate of 7.4%. So this is our reduction of maternal mortality. So we have established maternal death investigation methodology, where every maternal death has to be investigated, reviewed, and to identify the underlying and possible factors for maternal mortality. So the further reduction is relatively difficult because it started at a lower rate. In the maternal mortality data, we have observed that there is a changing of the causes of maternal deaths. We are now moving from having a higher rate of early direct deaths now towards higher proportion of indirect deaths. 55% of our maternal deaths are due to indirect maternal deaths. You can see in this slide on this side. So it's not very clear. The heart disease complicating pregnancy and the respiratory disease complicating pregnancy are the major killers of maternal deaths. And also the abortion deaths have been taken over in 2014 annual maternal mortality statistics as the third place. So we have new challenges and also the actions that have already started. Addressing cause-specific maternal mortality, medical problems complicating pregnancies. We have already identified establishment of few centers of excellence as critical care management centers for maternity care, where all these medical complicated, highly complicated pregnancies should be managed in these centers. Already National Planning Department has approved this project last week. Establishment of high dependency units in all comprehensive measures of hospital facilities and also the including multidisciplinary team management in medical programs. Quality improvement, dedicated maternity care services with adherence to national guidelines and protocols. Already many protocols are in place. We need to strengthen the implementation of these guidelines. We have issuing unmet need for family planning in maternal deaths. 33% of our maternal death cases had unmet need for family planning in 2012. So that means we need to strengthen our family planning services, although our coverage is 68.4% of contraceptive products. So we have many identified methods are available in the system, many guidelines and the protocols are available to strengthen the service delivery. We are working hard now to improve the family planning services, and also now we are doing the National Family Planning Program review to identify the gaps and deficiencies to come up with a strategic plan. So maternal death associated with gender-based violence and suicide, again suicide, there is an increase. So detection and early intervention for psychological problems during pregnancy and preparing is important. And also the conduction of psychological autopsies. They have already initiated work with the College of Psychiatrists and the Directorate of Mental Health. And also to have the case conferences on all suicide rates. HMIS and monitoring evaluation framework. We have a very strong health management information system on reproduction health, which was established in the 1970s. It was subjected to regular reviews and revisions. Accountability has been created among all service providers. When there's a maternal death, somebody is, the service providers are made accountable and they are questioned about the care that is provided, but it is a no-fault exercise. Monitoring and evaluation is inbuilt into the system. Look at the technical aspects of supervision. Administrative system also geared to strengthen the monitoring and evaluation. We have many reviews happening for maternal and child health, maternal deaths, and also the future income surveillance. Performance evaluation of the categories of the health staff is happened, and also the best performance are rewarded regularly. National program reviews are in place based on the need. We have done maternal and newborn health review, and also the short program review on MNH, and we have done now planning for national program review on school and adolescent health, and also the family planning national program review is already being implemented. So other contributing factors, which is the non-contributing factors, are the free education and equal opportunities for girls and boys. So this free education, including the university education, high female literacy and therefore the high male literacy as well. Increased age at marriage for girls for 24 years. Low transport costs to improve access to healthcare, and also available a widespread network of roads providing better access to electricities. Gender discrimination is minimum. I can't say no, but it's minimum compared to the Asian countries. And also the totally free health services in all tertiary care institutions, and also the primary care and health care, including bypass surgery in the government sector, is free of charge. So thank you very much for your patience hearing.
Thank you, Dr. Stevie, for your sharing of your experience. And the next speaker will be Dr. Henry Nguyen. She is Deputy Director, Program Manager of Maternal and Reproductive Health Division and Department of Public Health. She is responsible for programs and activities of maternal and reproductive health, such as safe motherhood, breastfeeding, adolescent reproductive health, and post-abortion care. So, she is going to present about the challenges and opportunities from moving MDG to SDG, Myanmar, in perspective of reproductive health.
Thank you, Madam Chair, and good afternoon to my senior colleagues and responsible guests. Thank you for allowing me to make this presentation. So, as we all know, it is an unfinished agenda regarding maternal mortality in our country as well as in other countries. So globally, there is only 44% of maternal mortality ratio decline, and in Southeast Asia region, 60% reduction we can make, including Myanmar. So we found that we have a short of targeted 75% for. So despite sustainable progress on maternal and child mortality, so we have to say that neither MDG goal 4 nor 5 targets were met. As well as in many other countries, the major increases in coverage of family planning, antenatal care, and stillbirth attendance. And now we have a comprehensive set of targets for addressing the health and well-being of women, children, and adolescents, which are adopted under Sustainable Development Goals. So these are the ambitious targets to prevent maternal and child death and achieve universal access to reproductive health care services. So Sustainable Development Goals, which were built on Millennium Development Goals, focused on mainly reducing poverty, but including wider sets of sustainable issues, which are relevant for all countries. So there are 17 Sustainable Development Goals with a number of targets under each goal, and 169 targets. And UN Secretary General's new global strategy for women's and children's and adolescent health 2016 to 2030 is also supportive agenda to achieve sustainable development goals. So let me share a few trends of some indicators related with MDG goal 5. So we found that there is marked reduction of maternal mortality ratio compared to 1990, which was around more than 400 per 100,000 live births, and according to our latest 2015 UN Interagency estimate, it was found that 178 deaths per 100,000 live births in Myanmar. And there is also a high rate of skill but attendance, but it was not met with our achievement of MDG target, which was more than 70%. And for individual care coverage also, we got more than 18%, so it was quite high coverage. So regarding contraceptive prevalence rate, we have more than 40% of contraceptive prevalence rate, but it was for married women, and that was around 17%. So we need to reduce this according to our FY 2020 targets. Now we are in the era of 2020 Agenda for Sustainable Development Goal. So related to our health development goal, it was goal 3, which we promised to ensure healthy lives and promote well-being all at all ages. So this is the shifting of the targets from MDG to SDG, and from MDG we have goal 5A and 5B. Now it became target 3.1 and the Sustainable Development Goal, which we commit to reduce the global maternal mortality ratio to less than 70 per 100,000 live births by the time of 2020. And related to universal access to reproductive health, we ensure universal access to sexual and reproductive health care services, including for family planning, information, and education by the end of 2030. And let me move to some points on challenges. So the integration is the most important challenges which we need to be pursued in multiple ways simultaneously. So not only the vertical integration, but also horizontal integration is also necessary across disciplines and all the dimensions of sustainable development goals. And we don't need to take responsibility by program. This goal is related with this program, so this indicator is responsible for this program. We used to say that. So actually, to achieve the sustainable development goals, all the programs need to be integrated, and each and everyone is responsible to achieve that sustainable goal. And another point of challenge is monitoring framework. As we mentioned before, there are numerous targets and many indicators. So to achieve such kind of data, and so availability of data became one of the challenges to monitor progress for ambitious targets. And another challenge is the resource allocation. We have manpower shortage, and other resource allocation needs to be reached to right place, and right allocation is required. And the last challenge is empowerment and rights. So we have the gender equity program and gender network, etc. And we need more empowerment on girls and women. And girl education is also important, and rights issue is also necessary. So no one is left behind, and rights for all, that we must do in progress. And we also have some opportunities. From the government and policy makers, we have high commitments for reduction of maternal mortality, child mortality, and maternal, newborn, and child health commitments. So this is one opportunity for our country. And in our country, we have civil society, many civil society organizations and networks of youth and faith-based organizations that those organizations are helping in referral system and emergency cases, such kind of activities we are participating. So it is one of the opportunities. And another opportunity is that we are now currently working on harmonization approach of RMCH++, which is a kind of mechanism for integration and harmonization among our implementing partners to have better outputs and outcomes. And we completed family planning 2020. And now we are implementing with great effort on family planning services implementation to reach to the grassroots levels, also through physical staff and also through volunteers. And we have some kind of coordination mechanism, regular coordination mechanism like lead working groups, technical strategic groups for MNCH, and finally, these are under Myanmar Health Sector Coordination Committee, MHSCC, which is the highest level of the ministry for coordination mechanism among UN, INGOs, and implementing partners. And the last opportunity we have, last point is that we are now in decentralization system since the country has opened up in 2011. Now we are promoting decentralized approach both in financing, commodity, etc., and all the authorities we are now implementing. So this is the end of my presentation, and thank you very much for your time.
Thank you, Dr. Hene, for your presentation. The third speaker will be Dr. Hene Dan, Director, Thai Health Ministry of Health. She has been working in the Thai Health Development Division for about more than 10 years, nearly 16 years. So today I request you to present roadmap to SDG Newborn Thai Health Perspective.
So thank you for that, good afternoon everyone. So my topics discussed here is Roadmap to SDG Newborn and Child Health Perspective. So Myanmar committed to achieve goals and targets in MDG by 2050, in which goal related to child health was good enough for to reduce and apply mortality rate to that by 2050. Now we have just passed the MDG era and look forward for next 50 years to achieve SDG. As we all know, there are 70 goals and 169 targets in SDG, in which goal related to newborn and child health is goal number 3. It is ensure healthy life and promote well-being for all at all ages. So there are 9 targets in target number 3. So one of the target is 3.2, which is related to newborn and child health. It is by 2030 and prevent deaths of newborn and children under 5 years of age, and to reduce neonatal mortality to at least as low as 12 per 1,000 life birth and underlying mortality to at least as low as 25 per 1,000 life birth. So as we chart a roadmap for SDG era, we need to know and understand the current situation of newborn and child health in Myanmar very in details. So that's why we have a look into the current situation of newborn and child health in Myanmar. So on the slide, upper picture shows that according to the census 2014, defined MR was 72 per 1,000 life birth and infant mortality rate was 16 per 1,000 life birth. But they haven't mentioned about neonatal mortality rate in this report. So as all we aware that there are different rates of mortality according to the different sources of data. Here we can see, according to the UN Interagency estimate, and the prime mortality rate was 50 per 1,000 life births, infant mortality rate was 45,000 life births, and newborn mortality rate was 26 per 1,000 life births. So therefore, we need to try to reduce the rate by half between 2015 and 2030 during 50 years period. So you can notice that this is very big challenge for us, but we are very confident to achieve these targets in 2030. So whatever source of the data, what we have seen in this slide, on this slide is decreasing trends of defined MR, IMR, and NMR. But the problem we face here is that very slow rate of reduction of mortality rate. And also we have our another challenge. This is the disparity. Here we can see the push in the district disparity on this slide. And also, not only in the district disparity, there are significant disparity between educational status of mother and girl conduct. Therefore, women and children in rural and those from poorer families have worse health and survival outcomes, as service delivery is weak there. So this is another big challenge to address to achieve SDG. Next please. And also, when we look at how many percent of newborn deaths occur when under 5 mortality, here you can see 53% of and 50% of deaths occur during the neonatal period. That's why we need to address newborn mortality to reach SDG. And also when we look at the causes of the newborn death, so the causes of newborn death are shown in this slide, and you can see that common causes are preventable causes such as prematurity, low birth weight, blood asphyxia, related jaundice, and neonatal sepsis. Similarly, causes of death between the age of 1 to 5 years are also preventable causes such as accident and poisoning, ARI, and diarrhea. These are the findings from the study of causes of death conducted in 2014 by the Ministry of Health. So although there are well-known evidence-based low cost and high-impact intervention for newborn and child health, and also as we in Myanmar have implemented all these interventions in the country. But the problem is the coverage of intervention cannot be able to reach universal coverage, 90 or 99% of coverage. And also another challenge is we can see inequalities in the coverage of intervention. Here I give one of the example of inequality in coverage of intervention according to the World Food Guidelines. And as Department of Public Health in 2014, we did have facility assessment including quality in 134 facilities from different levels of health systems throughout the country. So on this slide, you can see the color. So red color represents poor condition of our services, and yellow color represents need to strengthen, and green represents good condition. So regarding the availability of all essential infrastructure, supplies, and drugs for child care, newborn care, and ENK, you can notice there are many red color on these slides. Next please. And we also assess the accessibility of child health care services, newborn care services, maternal care services, including DDOC. So you can see the condition of accessibility of services in the country. So regarding the quality of care, assessment of data science and management of common science illnesses are weak even in the state and regional level hospital and sub-RAC. And counseling on continued feeding for sick child is also weak for all levels of health facilities. So based on the current situation, our roadmap to SDG is developed. Next please. So then the roadmap for SDG will be based on the current situation, and we have applied national health plan, national strategic plan for newborn and child health, other strategic plan related to newborn and child health, and also we have applied global strategy for women, children, and adolescent health, and also global every newborn action plan as a references. So while trying to achieve targets set in SDG, So what we focus here is continuum of care. We are going to provide interventions across the continuum of care from pre-pregnancy period to early childhood development and early childhood and through the delivery mechanism, starting from the family and community up to the referral level to promote newborn and child health and development. Also, another focus area is equality. We will focus on equality to ensure equitable access to quality newborn and child health intervention packages. And also, we are going to target the poor and enriched and the soft population groups with community-based intervention for disparity reduction. And another area is health system approach. So we do take into account various components in the health system by identifying the main gaps and priority actions to improve availability, accessibility, utilization, and quality of healthcare services for newborn and children to strengthen national healthcare system. So next area is integration, convergence, and cross-sector collaboration. Although there are separate plans, we are going to strengthen linkages and integration between the newborn and child strategic plan and program, contributing to newborn and child health in order to promote continuum of care. We are also collaboration with social and education services to promote multi-sector action to address the determinants of newborn and child health and development. So next area is partnership. So to maximize resources and avoid duplication, we do strengthen the partnership, coordination, and joint program with stakeholders, including UN agencies, INGO, NGOs, professional societies, and community. Another one is right-based approach. So to ensure protection of both vulnerable and group of children for health and development, right-based approach will be incorporated into interventions. The last one is community ownership and participation. The community-centered approach will be applied to generate a demand for health, foster improvements in family and community practices, and ensure community support for healthfulness. So these are the guiding principles for roadmap to SDG. So strategies to achieve SDG by 2030 is strengthening health system, objective. The objective of roadmap to SDG is set up evidence-based, cost-effective interventions through effective strategies within the health system approach and equitable coverage with quality. The second objective is to reduce neonatal mortality by improved home-based newborn care, early identification of sick newborns, and improved access to institutional newborn care of adequate quality. The third objective is to reduce common childhood illnesses related mortality by improving key family practices, community-based interventions. And the last, not the least, objective is to promote an intersectoral approach for continuum of care and cross-sectoral approach to address MSH determinants. So the target is to reduce NFI mortality rate from 50 per thousand liters to 25 per thousand liters by 2030. And the second target is to reduce neonatal mortality rate from 26 per thousand liters to 12 per thousand liters by 2030. So these strategies we are applying to achieve SDG by 2030. The first one is strengthening the system for provision of newborn and child care services, which consists of activities on enabling enrollment, availability of key providers and supplies, and increased availability and utilization of management information. The second strategy will be improving access to quality newborn and child care services, which consists of activities on prioritizing and the staff of hard-to-reach area, task shifting, increasing financial access, improving performance, and strengthening referral. The third strategies we are applying is to improve demand and utilize by engaging family and communities, which will include activities on implementation of overarching child survivor behavior change communication plan, community mobilization, and support for community volunteers. And the fourth strategy is ensuring an effective response for newborn and child in humanitarian situation. These are the activities we have implemented the activities to reduce defined MR and NMR. The major area are newborn area, and next one is management of hormone illnesses. The third is the foreign care for 6 newborn and children in hospital, and the last is community capacity development and cross-sector coordination. So when we have provided interventions or delivered the interventions through these delivery mechanisms such as family-oriented, community-based services, population-oriented schedulable services, first-level individual-oriented clinical services, referral-level clinical services, and standard referral system and referral linkages. So these are the interventions for newborn care. They are immediate family care, early initiation of exclusive breastfeeding, hygienic health care and skin care, neonatal resuscitation, newborn infection, sickness and management, and antenatal corticosteroid for preterm births, neonatal tetanus prevention, antenatal care package, antibiotics for premature rectal membrane, dengue mother care for preterm and newborn, extra support for feeding small and pregnant babies, and home visits for newborn care for 9 years. So we are going to more events around the time bound. That's why these interventions are very important and to reach universal coverage in the country. So now these are the interventions for infant and under-5 children. So these are the early initiation of breastfeeding and exclusive breastfeeding up to 6 months, safe and appropriate complementary feeding at 6 months with continued breastfeeding, vitamin A supplementation, pentavalent immunization, measles immunization, ORT for diarrhea, zinc for diarrhea, antibiotics for dysentery, sleeping under IDN, anti-malaria treatment for children, management of celiac malnutrition, prevention of mother-to-child transmission of HIV, management of HIV exposed and infected children, antibiotic treatment of pneumonia, hand washing and proper disposal of feces. So as a summary, I would like to focus the main activities to take action to achieve SDG targets by 2030. They are review policies for newborn and child health to further strengthen the enabling regulatory framework, advocacy for promoting newborn and child health and for mobilization of community on newborn and child survival, capacity building of various areas of health staff, scaling at community-based interventions, review and response, especially for timely surveillance and response, facility assessment for improving quality of care on newborn and child health, provision or access supplies of drug for newborn and child health, strengthen referral system, multi-region campaign on key family and community practices, supportive supervision, monitoring, evaluation, and feedback. The last one is intersectoral collaboration with UN and other development partners. So thank you for your attention.
Thank you, Dr. Minita, for your detailed roadmap to SDG newborn child health perspective. And although its time is 5 minutes overshoot, we can allow 1 or 2 questions from the audience for discussion. May I invite any discussion from the audience, please? If there is no discussion, Mark. Yes, please.
I'd like to congratulate all the speakers to present such a wonderful guidelines as to achieve the SDG and MDG and to save our children and mothers. So I'd like to discuss only 2 points. The first one is about keeping the model of Sri Lanka. We'd like to encourage institutional delivery, not the hospital delivery, but the institutional delivery attended by the skilled work attendant, so that it increase the care, especially the intra-maternal care for the mother and also the baby, so that we can get the 2 targets at the same time. So now the midwife training has increased to diploma level, and a lot of posts for a midwife has been created and to be supervised by the township midwife officer in each township, so that we hope that this encouraging institutional delivery is a key point to get our targets in future. That is the first one to support the Sri Lanka report and also to give a suggestion to our Myanmar Maternal and Childhood Division. The second point is about the strategy in achieving, reducing under 5 infant mortality and neonatal mortality. Because keeping the neonatal mortality as low as possible will save about 50% of the infant and under 5 mortality, as mentioned from all the data. So it says that one point is the collaboration between the maternal or intrapartum care and the care of the preterm baby. That's a one strategy should be the anticipation of preterm delivery and keeping activity of antenatal corticosteroids to increase the surfactant stimulation and transfer to the township or district hospital where the pediatrician are there and giving the preterm neonatal care, which may be better than the neonatal care in the community. That is one point to suggest to prevent the neonatal mortality. Thank you. Because I think we need to discuss just to give our interest to the presentation, which is very useful for Myanmar. Thank you.
Thank you, Alma.
Thank you. Good afternoon, all. It is a great appreciation for me to listen about this topic, and this day is so clear. I want to change our opinion about global sexual reproductive and health rights. Actually, what do you call review the major activities to action, like you talk about review policies, provision of essential drugs for maternal and child health, support monitoring, evaluation, feedback, and collaboration. Actually, as you know, that if we run one program, of course, it means that we do the comprehensive program until the target will be reached. Okay, but why international program do change from MDGS Millennium Development Goal to Sustainable Development Goal? It means that when we change the program will be our target. It is makes people more business, which is it isn't rich actually. Why do we change to SDGs, right? And how can implement it? Do you believe that the target of SDGs will be reached without our commitment, our implementation, and our collaboration with each other between NGOs, government, and public sector, and youth? Thank you for all, and thank you for your attention. Good afternoon.
Thank you very much for your comments. And I think there is another one. Yes.
Thank you for. My name is Christine Parker from Ireland. Thank you for a very good presentation. My question is addressing to Dr. Mimi. Would it be possible for you to express more about your strategies in terms of achieving the 2030 goal of 70 by 100,000 reduction of maternal mortality? Thank you.
Thank you for the question. So, Our strategy will be according to our 5-year national strategic plan, which was now we are currently making reference to that strategic plan 2014-2018. So we have detailed strategies, mainly focusing on bus-based services, and we have to empower the community involvement and strengthening the health system, including our reproductive health commodity security. Now we are implementing that our logistics system in pilot township and going to roll out to cover nationwide. So such kind of strategy, we have detailed strategies we have. Thank you.
I'm Dewar from Myanmar. I would like to ask the Vice Speaker, Dr. Community. From your data, all of your data show the researchers for the coverage up to 2050. But from your data, upon the coverage, and then you show the data up to 2007. So can we know the other data beyond the 2007 to 2050? Thank you.
Yes, for that consumptive prevalence rate and endemic, we use the survey data only. So the survey was the last survey we have done in Myanmar is fertility and reproductive health survey. It was in 2007. So now we are doing demographic health survey. So when that demographic health survey DHS finish and the results come out, we have the new result or new data for consumptive prevalence rate as well as for endemic. Thank you.
Is there any more discussion from the audience? If there is no more discussion, I would like to wind up our symposium. And in our symposium, we all have a global and regional overview, very important, and we have a very comprehensive and precise data and presentations from the expert from the ratio, as well as we also have learned the experiences of the success in achieving the MDG goal 4 and 5 in Sri Lanka. So it is very good points for our country, because we need to improve a lot to reach the targets of the SDG goals. And then we also have information on our Myanmar side, challenges and opportunity for moving from MDG to SDG in Myanmar, as well as we have a detailed roadmaps to SDG, newborn and childhood perspective. So it is a very complete and very good symposium, and I would like to thank all speakers as well as all the participants who have participated in discussion. And I also thanks to the WHO